Hello, I'm Ravi Vij from MyCancerHaven, and we are delighted to welcome you to our inaugural Expert Roundtable series, Guidelines in Action, Empowering Community Physicians in the Care of Patients with Multiple Myeloma. MyCancerHaven is a 501(c) organization with a mission to support and empower patients, caregivers, healthcare professionals, and healthcare organizations using dedicated, innovative solutions tailored to unique challenges of cancer care. The goal of this expert roundtable series is to focus on the applications of the available evidence for the care of patients with multiple myeloma. To do this, we have brought together an amazing panel of experts who I'd like to welcome today and thank them for taking time out of their busy schedules to sit down and have this discussion today. Please welcome Dr. Natalie Callender from University of Wisconsin in Madison, Wisconsin, Dr. Ajay Chari from the University of California in San Francisco, Dr. Craig Cole from Carmonas Cancer Institute in Detroit, Michigan, Dr. Binod Dhakal from the Medical College of Wisconsin in Milwaukee, and Dr. Adriana Rossi from Mount Sinai in New York. This program is made possible by a generous unrestricted grant from Sanofi and Janssen Pharmaceuticals, and development has been supported by Cancer Communicator. The focus of today's program is treating and managing patients with relapsed or refractory multiple myeloma who have received 1 to 3 prior lines of therapy. The treatment for patients with multiple myeloma is obviously getting complex with numerous active therapies that are often used in combination with no simple algorithm. And that complexity is amplified in this setting, especially. The current guidelines to the NCCN have 40 regimens listed, and the field is further evolving with some newer data coming in. The multitude of trials that have been done that have compared 3 drug studies to 2 drug regimens, and none of these 3 drug regimens have been compared head to head. The biggest news in this space was the availability of CAR T cell therapies. We have 2 BCMA-directed therapies that were previously approved for heavily pretreated patients after 4 prior lines. And then in April, the FDA approved, literally simultaneously, cilta-cel for patients who had 1 prior therapy, including a proteasome inhibitor, an immunomodulatory agent, and refractory to lenalidomide based on the CARTITUDE-4 study. We also had ide-cel that was approved after 2 prior lines of therapy, including an immunomodulatory drug, a proteasome inhibitor, and a CD38 monoclonal antibody. Ajay, your practice changed with the advent of CAR Ts in the 2nd to 4th line space?
Definitely. I think the CARTITUDE-1 data was probably the single most efficacious agent we've had in myeloma, with a PFS of 3 years with heavily treated patients. But all of those initial Carmine CARTITUDE studies were in heavily treated patients, and so those are accelerated approval. So we needed this phase 3 study for definitive approval, which puts the efficacy into context with safety. And I think the fact that this, particularly cilta-cel's PFS, is not reached, but the hazard ratio, despite control arm having a PFS of 12 months, still was a 75% improvement in likelihood of progression or death, which is really impressive. So I think this gives us ability to use CAR Ts earlier. I don't necessarily think every patient should do it at first relapse, but I think the other thing that we need to remember with CAR T is what I like to call brain to vein time. It's the time that a community doctor may think about referring a patient to actually getting CAR T. That's a long time. And by having an approval as early as 2nd line, you can start planning, getting insurance approval, apheresis slots. So it actually allows you to plan better. And I think, I'm sure we're going to talk about more. One of the most interesting things about CART4 was not necessarily the efficacy, safety for the overall population, but what happened to those patients who progressed prior to lymphodepletion. And I think it's just a reminder that we have to control myeloma, even in 1 to 3 lines, before taking people to CAR T.
I think that all the individuals, correct me if I'm wrong, probably already incorporating it in somewhere in the 2nd to 4th line space now. Is that correct?
I think for me, I think we're still sort of trying to figure out who would be the ideal person for 2nd line use. I wouldn't say that we think every patient at 2nd line needs to consider CAR T at that point. A lot of it depends on the nature of that individual. So if they have high risk disease, rapidly progressive, very unstable, I think we are thinking that we would like to do a CAR T in that kind of individual, but just as Dr. Chari pointed out, sometimes that's actually quite difficult to get that person stabilized enough to be able to get them in to be seen and manufacture the cells and then get them to the LD chemo and actual transplant. So I think along to his point is we really do think for those patients who maybe have high risk features at diagnosis, or maybe they've had an intervention, maybe autologous stem cell transplant, but clearly are showing, say, progression at a year or 18 months. I think those are the individuals that we think should be referred in for a discussion at a minimum about the role of CAR T.
You took the question out of my mouth. So, Craig, who are you considering for CAR T in a second to fourth line? What is your algorithm?
Yeah, in fact, we had a couple meetings among the Hermanos myeloma practice about kind of what our algorithm is, and definitely those functionally high risk patients, people who we've been using quads up front and who, despite them being either high risk by cytogenetics or just having standard risk and relapsing, on a quad, we're really pushing those patients to getting CAR T sooner than later. And just like Natalie and AJ had mentioned, those patients that are rapidly relapsing and have a more aggressive presentations, those with extramedullary disease that come in, we're moving to CAR T in second and third line much quicker. But that leaves, just like I said, that leaves a lot of patients that are out there that have, kind of standard myeloma, that kind of have, the indolent, B cell kind of disease that we're using other therapies for before we take them to CAR T.
So, Vinod, when would you want the community doctor to refer the patient to you for a CAR T?
As early as possible. As I said, if you look at the CARTITUDE-4, there are less than 10% of patients who are not able to get as treated, right? Because they fell off because they couldn't handle the disease. They're functionally high risk, even though, maybe they might have standard risk by cytogenetics. So I think identifying those patients early on so that you can bridge them effectively and get them successful to CAR T is the key. I think I would like to answer this in the context of, two things. One is, when the CAR T was, this second line approval was first made, of course, we didn't have the CARTITUDE-4 survival data. Now we have survival data, clearly showed the survival benefit, which is pretty important, right? And number two, what is the evolution of the treatment in the first line? I mean, we have now quadruplet QuadX, approved in the first line. But even before that, we have been doing quad majority of the patients based on Griffin data. So I would say majority of patients right now in second line are quad exposed. It may not be like all patients, but next 2 to 3 years, it will be all quad exposed. So right now, I mean, third line and beyond, there is no question. They are CAR T. They have to be considered for CAR T. For second line, I think it's up for discussion for some patients, like what Greg said, like indolent relapse, they haven't seen CD38. You could argue that, maybe they get CD38 based regimen and can get like 2 years PFS with Candor and even longer with IKEMA. But beyond that, I think CAR T definitely needs to be considered and discussed and try to see if they're eligible. If they're eligible, I would definitely give them the CAR T. No question about the high risk, no question about young patients, early relapse, and those definitely should go into CAR T.
So, Adriana, would you give CAR T to a person who has not yet been penta exposed?
Yes, I think that's, I echo very much what everyone has brought up. One of the things I think we really benefited that changed with the new indication is exactly to Ajay's point, the ability to control the disease. Because after they're penta exposed, they're relapsed on everything, having a successful holding therapy and bridging therapy become more challenging. So the 2 points I really agreed with the most is starting the conversation early, because even if the patient may not need the CAR T at that second relapse, they will eventually. So starting that conversation, having the patient be known by a CAR T center and having that CAR T physician work with a community partner and, tuck in that patient avoids a lot of the hurdles that we see. And so for a standard risk patient who got years out of their first induction, absolutely, I think that patient can probably benefit from non-CAR T therapies, but having them on our radar and be thinking about which therapy and when to bring them back in. I tend to always try to practice by the book and evidence-based and only start a new line of therapy once IMWG criteria have been met for PD. But luckily for most of our patients, we watch them so closely, we can see it coming. And so having everything aligned, so the day that protein level or end organ damage pops up, we're ready to take action.
Just another comment, I think that in terms of when to refer people, Ravi, that you mentioned, I think all of us here have clinical trials for CAR T, and they have different eligibility criteria, different sort of entry points for patients. But that's another reason to refer people early, because then we could sort of guide people to the most relevant clinical trials that are out there now for CAR T, because there are quite a few that are under development or available.
Thanks for bringing that up. That's an excellent point. Ajay, so how do you decide on candidacy for CAR T? For a community doc, who is it that they shouldn't send for a CAR T?
I think probably the only exception would be somebody with multiple comorbidities and frail. But short of that, I think many of us would agree that more patients are CAR T eligible than transplant eligible, right? And this is something that I think we should really highlight. If you look at the quality of life data, we know that transplant has a 3-month impairment of quality of life because of the nausea, vomiting, weight loss, fatigue, count recovery, all of those things. But one of the most beautiful things about CAR T, it's the first time in my 20 years that we've cut the umbilical cord between patients and the cancer center, right? You're actually discontinuing therapy. There's no maintenance therapy. And, I think Binod already mentioned, we're doing quadruplet for most patients, including some of those really more fit older patients, right? Where that distinction's getting blurred. Some of those older patients may not choose to do transplant as a consolidation. But when you collapse anybody who got a quad with or without a transplant and is on maintenance, especially if they're on more than one drug maintenance, I think CARTITUDE-4 data was specifically for len refractory, but many patients are on additional medications, right? CD38 or PI. How do you salvage those double refractory patients if they're on maintenance, right? And also, we know there's a lot of treatment fatigue. We can all say we're going to do what the clinical trial said and give these parenteral drugs till progression or whatever the duration was, but there's a lot of real-world discontinuation of drugs that are parenteral. And even lenalidomide has a lot of chronic toxicities, impairment of quality of life, diarrhea. So I just wanted to highlight that for the CAR T, yes, we'll talk about side effects, but from a patient and quality of life perspective, there's no treatment as good as being off all treatment, right? So that's really, I think, valuable.
So Craig, do you have an age cutoff, performance status cutoff for your CAR Ts?
Really, age is a number. And so I think that the oldest person we've done CAR T has been up in the 80s. The other person was very healthy. And, performance status wise and comorbidity wise, it really is. I think the important point that everyone's been echoing is to, establish those relationships early and to have patients come in to be seen by the CAR T team early so that we can get a sense of what their performance status is and what their performance status, may be impaired by the progression of their disease, and to be able to figure that in and looking at their comorbidities. Yes, cirrhotic liver and end-stage, lung disease, end-stage liver disease, can be difficult. But, otherwise, I think, making those early referrals, getting to know these patients, seeing what their performance status, really is before it may decline, really is golden in making a decision about, should they go through a CAR T.
If you can be president of the United States, you probably can be considered for CAR T.
I guess there's this terminology that is sometimes abused, the bridging therapy. So classically, bridging therapy, I think, is meant to be after the collection of the cells and before infusion. But some people use it more broadly, even before the collection. They call it bridging therapy. I hear, words like holding therapy sometimes. So Adriana, what is it that your policy is in that period before the pheresis?
Yeah, I think to your previous question, it is very important to use bridging to be specifically to the post-pheresis, because I do think of it very differently. We certainly have a number of patients who are using bispecifics as the bridging, meaning after we have our T cells in manufacturing, maybe tire out some T cells. Sometimes we may need to use alkylators like a combination chemotherapy to have a nice, rapid, efficient debulking. But prior to apheresis, holding is the most popular term I've heard. I'm happy to, open the poll to other names, but it should have its own name, because in that space, we do want to maybe either avoid or limit the bispecifics in order to allow for T cell fitness, certainly minimize certain alkylators. Things like bendamustine can be incredibly lymphodepleting. So you're sort of setting the patient up for failure, unfortunately. So thinking about those two differently, I think, is very important. But other than alkylators and the bispecifics, I think generally anything is up for grabs. And to your point, we really want to debulk, but we don't need that complete response, right? The T cells will get that done. These are all therapies that need to contain the disease, because we know high tumor burden and a rapidly growing tumor are the ones that set us up for highest toxicity and can compromise efficacy.
So there was a CARTITUDE study where they looked at prior therapies prior to getting cilta-cel. And so we said, let's say cilta-cel's PFS is 3 years. If you got a prior BCMA bispecific, it dropped to 5 months. And if you got a prior BCMA ADC, it dropped to 9 months. Now, some of the limitations there is those patients might have been getting those products at full dose intensity until progression. So there's a data gap. Maybe if you discontinue your bispecific or discontinued an ADC and had a long treatment-free interval, perhaps that might be okay. But I would just caution for the community audience, because Bella may be coming to a store near you based on the studies, and I know we're going to talk about that later. But I would also caution from pulling the trigger on any BCMA product without speaking to the CAR-T referral center, because the last thing you would want to do is compromise somebody's 3-year PFS to 9 months because of the treatment selection prior.
Yeah, I would just underscore, just to say again, for the goal here is probably a phone call to the CAR-T center to discuss the holding treatment would probably be ideal, because I think sometimes the other misconception may be that a patient has to be in this complete remission before you could go ahead now with either collection or CAR-T, and you don't want that individual to have the potential to just sort of relapse and then somehow lose their ability to go ahead with CAR-T. So I think we would all really emphasize making that discussion happen early on about holding, and then, just sort of step by step, what would be the plan for that individual.
So again, Ajay, have you had experience with CAR-Ts in renal insufficiency patients? Some of patients with myeloma, unfortunately, even are on dialysis. So I know there have been actually some reports now of patients on dialysis getting CAR-T. So what is your view there?
I think, to me, the main AE that you have to wonder about of a patient to tolerate is high-grade CRS, right? And if somebody is very hypotensive heart failure, that might be a little problematic with fluid shifts, et cetera. But I think dialysis, many of us have done dialysis patients. The key is just what conditioning regimen you do, because fludarabine is renally cleared, so that needs to be adjusted based on each institutional practice. Some people have just done Cy alone for those patients as opposed to dose reducing the fludarabine. So depending on the degree of renal insufficiency, fludarabine needs to be adjusted. But I think these patients were excluded from clinical trials, right? And that's in some ways, when these bispecifics and CARs became available, the first group of patients, the first wave of patients getting them were the study ineligible patients, right? Heart failure, renal failure, older patients, comorbidities. And I think we have to help all of these patients, not just those cherry-picked, perfectly healthy patients. So yes.
So Binod, what about this concern about secondary malignancies? Have you, been restricting your use because of secondary malignancies?
The short answer is no. If you look at the rates, I think, in the late relapse, it is about 10%. I mean, more concerning is the MDS AML, right? So if you look at the CARTITUDE-1 data, 10 out of 97 patients develop that. But I think once you move in early lines, I think that number has gone down. And I'm not saying that this is not a trivial number that we can just ignore it. This is something that we definitely need to discuss with the patient. But what is the risk versus benefit, with that number? I don't think that had changed, at least based on the latest follow-up, the CARTITUDE-4. I think the MDS AML rate is about less than 3%. So I would still think that its benefit is outweigh the risk in overall, like in terms of having survival benefit, having the long PFS. But again, we just need to follow along, and I think we have some real world studies also showing that the rates of MDS AML is not that really high as what's in the CARTITUDE-1 patient population, because we just had a paper out from the consortium yesterday. it's about, I think 5% or less. I think those kind of data would guide or perhaps, kind of help us in making a safe decision with the patient. But at this point of time, the benefit seems to outweigh the risk, at least in my practice. And more importantly, I think I would say that we will, in the future, would understand what are the risks for developing this in these patients. Are there specific CAR-T inherent risk, or this is because by myeloma, with the treatment in the patient-related factors that is contributing more to that. So I think just based on CAR-T1, CAR-T4, I would say this is a patient-related factors. But whether it is inherent to CAR-T, I think further research will help us understand.
I do think when we're counseling patients, we have to discuss this because the CARTITUDE-1 data was 10%, but the latency period was only a year and a half, right? So it's not that this was many years later, because of course you could say that if you're alive long enough from your myeloma, you're going to see those. But that 1.5 year is really important because now when you go to CART4, the signal is lower. I agree. It's not 10%, maybe 3%, but it's still higher than the control arm, right? And it's still only a year and a half follow-up. So this goes back to our earlier discussion. If you're a standard risk patient who has multiple salvage options, it's fine to say, and this is the difference between population and individual, right? At a population level, yes, 3% is not that high. But if you're one of those 3%, your now life is defined by this new cancer and secondary cancer, right? And in CARTITUDE-1, we did see a lot of patients who died with these myeloid malignancies. So I think if you have the longer your projected natural history with myeloma, the more this even 2% risk of SPM may factor in. And, kind of a little bit of Len maintenance SPM story. If you're a good risk patient, you may not be as excited, but if you're a high risk patient, I think they'll still do it because myeloma will be their life-defining event. So there's a small, I think, relationship that we need to still understand the pathophysiology of.
Right. And I was just going to add the two things is, again, the more highly treated, they've received a lot of alkylators. Most of them have had a transplant or two. And so there's a lot of other damage that is hard to tease apart the contribution of CAR-T versus the other things that we have done. And the other is we are starting to learn that there are certain patients when you're able to look before, there may be CHIP and other signals. So that can infer and sort of feed our patient selection as well moving forward.
Yeah, I think the CARTITUDE-4, that out of 5 patients who developed, AML, out of 7 patients, 5 had pre-existing mutation. So right now, I think if you ask me, I don't do that. And I don't think that is guiding me to choosing versus not choosing. But I think going forward, once we have more controlled studies like CARTITUDE-4, KarMMa-3, and there are a lot of other, studies that the risk over there and potential mechanism of why that happened to a particular patient probably would help us, a little bit more on that.
But it is that discussion between us and their primary hematologist and the patient about the risks and benefits, and definitely in discussing, with my own patients about CAR-T, we talk about a lot of these risks and benefits. And the good thing is that more and more we're seeing, just like everyone had said, these specific populations of patients where that risk is a bit higher, and therefore the benefit relatively is better in those patients that can be risky going into CAR-T for second malignancies.
So one thing, I guess, before we wrap this section up is about access. One of the things obviously has been an issue that we have had limited slot availability in the past. So what is the slot availability looking like at your center now, Natalie?
So that has become much less an issue in the last year and a half, I think, for all of us, that we really are usually able to secure a slot when we need to. But it's still, and I appreciate Dr. Chari's remarks about, this is very different than an auto transplant. And when CAR-T goes well, it's great. But again, in terms of an informed conversation, as Dr. Cole was mentioning, I think you do have to tell patients that they're going to be here near your center for a month. They're not going to be able to drive. That can be a significant burden on a family, particularly if that individual is getting the CAR-T as the breadwinner. So there's a lot of rearrangement of lives that have to happen for a person to come for CAR-T. And then, of course, there's the possibility that they can be one of the few individuals who has a longer term complication, such as, infection or neurotoxicity, something like that we have to prepare them for. Some of the commercial products do have programs that help subsidize some of the costs, which is great. It's wonderful that we have them, but there can be a real significant burden on the family to arrange all this and figure out where they're going to stay close to us for that 30 days or so.
You certainly bring up a very valid point that we need to be aware of some of the logistical issues and the long-term issues as well. I presume everybody has been now having more ready access to CAR T, and slot availability has not been a limiting factor. So this has been a great discussion about the data and now how we use this data and our guidelines for the care of our patients that we will explore in our next segment.